Welcome to vpod.ai, everyone.
Glad to be here.
Today, we're doing a deep dive into something you've probably been hearing a lot about lately, GLP-1 agonists.
Mm-hmm. Definitely a hot topic in health circles.
Yeah, exactly. We want to unpack what these medications are, how they work, and why there's just so much excitement around them, especially for things like type 2 diabetes and obesity.
Absolutely. They really do represent
Yeah.
quite a shift in how we're thinking about metabolic health.
How so?
Well, think of them as unlocking benefits that go beyond just controlling blood sugar. It's more complex than that.
Okay, interesting. And this deep dive, it's sponsored by our friends at StoneFly.
Right, StoneFly. They're leaders in data center solutions.
Yep, offering high-performing, elastic, always available IT infrastructure.
And their Stone Fusion operating system, that's pretty impressive, supports data-heavy processes, applications, basically anywhere, anytime.
Definitely worth checking out their cloud, storage, backup, DR, and hyperconverged solutions if that's something you need.
For sure.
So our mission today is really to give you a clear picture of these GLP-1 agonists, the basics, how they work, the potential upsides, without getting, bogged down in super technical stuff.
Let's do it.
All right, so let's start right at the beginning. What exactly are GLP-1 agonists?
Okay, so simply put, they're a class of medications. Their main jobs are to help lower blood sugar levels and also to promote weight loss.
Okay, so two major things there.
Exactly, which makes them a really valuable part of the treatment plan for people managing type 2 diabetes or obesity.
And how do you typically take them? Are they pills?
Mostly, no. The majority are actually injections,
Hmm.
subcutaneous injections, meaning just under the skin.
Ah,
Okay.
like insulin sometimes.
Very similar, yeah. Common spots are like the belly, outer thighs, upper buttocks, back of the arms, places like that.
Gotcha.
Though, interestingly, one of them, semaglutide, does come in a tablet form now.
Oh, really? That's
Yeah.
good to know. An option for people who prefer not to inject.
Precisely. Gives some flexibility.
Now, are these like brand new, just discovered yesterday?
Huh. Not quite yesterday,
Yeah.
but they are relatively recent in the grand scheme. The very first one got FDA approval back in 2005. That was exenatide.
2000, okay, so less than 20 years.
Right. And since then, research has been going strong. Scientists are constantly looking into other ways these meds might help. It's a really active field.
So if someone gets prescribed one of these, say for diabetes, is that like the whole treatment? Just take the shot and you're good.
That's a crucial point. Now, while these medications are, very effective tools, they aren't a standalone solution.
Okay.
Lifestyle changes, diet, exercise, they're still absolutely fundamental for managing type 2 diabetes or obesity successfully.
So the medication is a helper, not a replacement for a healthy habit.
Exactly. Think of it as a partner working alongside those lifestyle efforts.
Right. Could you maybe list a few of the names? People might hear brand names and wonder if that's what we're talking about.
Sure, yeah. There are quite a few out there now in the U.S. market. You've got dulaglutide, which is Trulicity,
Oh.
exenatide, that comes as Biete, and also an extended release version called Bydureon.
Got it.
Then there's liraglutide, known as Victozi, lixanatide, that's Adlixin, and the semaglutide we mentioned.
Right, the one with the pill option.
Yeah, the injection is Ozempic, and the tablets are Rybelsus.
Okay, quite a list.
And there's actually one more category worth mentioning quickly, dual GLP-1 GIP receptor agonists.
Oh, what's that?
It's similar, but it targets two receptors instead of just one. The main one available now is tirzepatide, brand name Mounjaro.
So potentially even more potent.
Sometimes, yes. Acting on both pathways can lead to sometimes even stronger effects on blood sugar and weight.
Fascinating. Okay, so we know what they are, roughly how they're taken, but the big question is, how do they actually work inside our bodies? What's the mechanism?
Right, this is where it gets really cool, biologically speaking. These medications essentially mimic or copy a hormone our own bodies make. It's called GLP-1.
GLP-1, and where does that come from?
It's produced naturally in our small intestine. And this hormone, it does several really important things after we eat.
Like what?
Well, first, it signals the pancreas to release insulin. Insulin, as most people know, helps lower blood sugar.
Okay, standard insulin function.
Yep. But GLP-1 also tells the body to dial back on releasing glucagon. Glucagon is another hormone, but it raises blood sugar. So GLP-1 helps keep that in check.
Ah, so it works on both sides of the equation, lowering and preventing rises.
Exactly. And there's more. It also slows down how quickly food empties from your stomach.
Why is that important?
By slowing things down, the glucose, the sugar from your food, enters your bloodstream more gradually. You avoid those big, rapid spikes in blood sugar right after a meal.
Okay, that makes sense. Smoother curve.
Right. And then there's a really key effect, especially for weight management. GLP-1 increases satiety.
Satiety. Feeling full.
Exactly.
Okay.
It basically tells your brain, hey, we're satisfied here, which helps reduce hunger and overall appetite.
Wow, that's quite a portfolio for one hormone.
It is. But here's the catch with the natural stuff.
There's always a catch.
Yeah. Natural GLP-1, it only lasts for a couple of minutes in the body before it's broken down.
Oh, really? That short?
Yep. Very short-lived. And that limitation is precisely why these medications were developed. They're designed to stick around much longer.
Ah, so the drugs are like a long-lasting version of our own hormone.
That's a great way to put it. The GLP-1 agonist medications, they bind to the same docking sites, the GLP-1 receptors, as our natural hormone.
Okay.
And by doing that, they trigger all those same beneficial actions: insulin release, less glucagon, slower digestion, feeling full but for hours or even days, depending on the specific drug.
And I assume higher doses mean stronger effects.
Generally, yes. Higher doses tend to lead to more pronounced effects, which is why doses are often adjusted based on the individual's needs and response.
So for someone with type 2 diabetes, how does this translate day to day?
For them, it's incredibly helpful for regulating blood sugar, promoting insulin release when glucose is present, and slowing down that post-meal glucose absorption. It just leads to much better control overall.
A more stable energy flow, perhaps.
Exactly. A more controlled, steady release of energy from the food they eat.
And the weight loss aspect that often gets talked about, where does that mainly come from?
That largely stems from the satiety effect, that increased feeling of fullness.
Right.
When you feel fuller sooner and for longer, you naturally tend to eat less. Your appetite decreases, hunger pangs are reduced, and over time, that calorie deficit leads to weight loss for many people.
Okay, that clears up the how. So when would a doctor actually think about prescribing one of these? What are the main situations?
Primarily, they're prescribed for two key conditions: managing type 2 diabetes and treating obesity.
Let's take type 2 diabetes first. When might it come up in that context?
Okay, so for type 2, the FDA has approved them specifically to help manage blood sugar levels. A doctor might bring them up if, say, metformin.
Which is often the first-line drug, right?
Exactly. If metformin isn't getting the job done well enough, or maybe someone can't take metformin for safety reasons, or if their A1C,
The long-term blood sugar measure.
right, that 3-month average.
Yeah.
If the A1C is still too high despite other efforts, a GLP-1 agonist might be added.
And it's used alongside lifestyle changes.
Oh, absolutely.
Yeah.
Always alongside diet and exercise modifications. And sometimes they're prescribed together with other diabetes medications too.
What about type 1 diabetes? Any role there?
That's still kind of an exploratory area. Research is ongoing.
Ah,
Some studies suggest potential benefits, maybe helping with blood sugar control or weight in people with type 1, but currently they are not FDA approved for type 1 diabetes.
so not standard treatment.
No. You might see it used off-label in very specific cases, but that's a careful decision between the patient and their specialist. Definitely not routine.
Okay. And then for obesity, when are they used there?
For obesity, specific ones, semaglutide and a higher dose of liraglutide, have got the FDA nod for treatment.
Treatment of obesity itself, not just weight loss as a side effect.
Correct. Specifically for individuals with a BMI, body mass index, of 30 or higher.
Which is the clinical definition of obesity.
Right. Or they might be considered for someone who is overweight BMI between 25 and 29.9 if they also have other weight-related health problems like high blood pressure or cholesterol, where losing weight could really help those conditions.
But again, it's not just about the medication for obesity, is it?
Definitely not.
Mm.
Effective obesity management is really a multi-pronged approach. It usually involves diet, exercise, behavioral therapy, or counseling. And sometimes, even bariatric surgery might be considered. The medication is one tool in that bigger toolbox.
Makes sense. A comprehensive strategy.
Exactly.
You mentioned the injection frequency varies. Can you give us a quick rundown? Is it daily, weekly?
It really depends on the specific drug. Let's see, dulaglutide, Trulicity, that's once a week.
Okay.
Exenatide extended release by Dorian is also weekly. Same for semaglutide injection, Ozempic, and tirzepatide, Mounjaro. Those are all weekly.
So several weekly options.
Yes. Then you have liraglutide, Victozi,
Yeah.
and lixisenatide, Edlixin. Those are daily injections.
Daily. Okay.
The original exenatide Baya is actually twice a day. And the semaglutide tablets, Rybelsus, are taken once daily.
Wow, quite a range.
It is. That's why it's absolutely critical, follow your doctor's or pharmacist's instructions to the letter on how and when to take it.
Absolutely. Now, beyond the main effects on blood sugar and weight, which are already pretty significant, are researchers finding any other potential benefits?
Yes, and this is a really exciting area of ongoing research. There's growing evidence suggesting other positive effects.
Such as?
Well, some studies indicate they might help lower blood pressure. Others show improvements in lipid disorders like cholesterol levels.
Okay, cardiovascular benefits then.
Potentially, yes. There's also data suggesting improvement in non-alcoholic fatty liver disease. And perhaps most importantly, there's emerging evidence suggesting they might reduce the risk of major cardiovascular events like heart attacks and strokes, and also potentially reduce the risk of kidney disease or slow its progression in people with diabetes.
Wow. So not just metabolic, but potentially heart and kidney protection too.
Exactly. It's looking like these drugs might offer multi-organ protection, which is quite remarkable. Research is still ongoing to fully confirm and understand all these links, but it's very promising.
That is a compelling list. But like any medication, there must be downsides too. What about side effects? What are the common ones people might experience?
Yes, absolutely. Side effects are possible. The most common ones tend to involve the digestive system.
Like stomach issues.
Yeah, things like loss of appetite, feeling nauseous, sometimes vomiting or having diarrhea.
Are those usually temporary?
Often, yes. They're more likely when you first start the medication or when the dose is increased, and they tend to lessen over time for many people, but not always.
Okay. Any other common ones?
Some people might experience dizziness, maybe a slight increase in heart rate, mild tachycardia. Infections, headaches, indigestion have also been reported,
Mm.
and sometimes, a bit of temporary itching or redness right at the injection spot.
All right, those sound manageable for many. Are there any rare but more serious side effects to be aware of?
Yes, although they are uncommon, there are some potentially severe side effects listed. These include pancreatitis.
Inflammation of the pancreas.
Correct. Also, a rare type of thyroid cancer called medullary thyroid cancer has been seen in animal studies, leading to a warning. Acute kidney injury is another rare possibility, and potentially a worsening of existing diabetes-related eye problems called retinopathy.
Okay, those sound serious. Important to know the risks.
Definitely. And it highlights why medical supervision is so important.
What about other general risks? Allergies, pregnancy.
Good questions. Allergic reactions are possible, like with any drug, and in rare cases they could be severe, like anaphylaxis. And pregnancy is a key consideration. Based on animal studies showing potential harm to the fetus, these medications are generally not recommended during pregnancy.
So birth control is important if you're taking these.
Yes, effective contraception is usually strongly advised for individuals who could become pregnant while using GLP-1 agonists.
What about low blood sugar, hypoglycemia? Is that a big risk?
Actually, when GLP-1 agonists are used by themselves, the risk of hypoglycemia is generally quite low.
Oh, that's good.
It is. Because their effect on insulin is glucose-dependent, they work more when sugar is high. However, the risk does increase if you take them along with other medications that also lower blood sugar,
Like what?
like sulfonylureas, which are an older class of diabetes pills, or especially if taken with insulin itself.
So combining them needs careful management.
Very careful monitoring, yes. And people need to know the symptoms of low blood sugar: shaking, sweating, dizziness, fast heartbeat, hunger, confusion, paleness, nausea.
And know how to treat it, presumably with sugar.
Correct. Usually consuming some fast-acting carbohydrate or sugar source.
It definitely sounds like keeping in close touch with your doctor or healthcare team is essential when you're on these meds.
Absolutely paramount. Regular appointments are needed to see how things are going, adjust dosage if needed, and manage any side effects.
When should someone specifically reach out between appointments?
Definitely call if side effects become really bothersome or don't go away, or if you feel like the medication isn't working as expected. Also, importantly, if you're thinking about stopping the medication for any reason, talk to your provider first. And of course, if you become pregnant or are planning a pregnancy.
Great advice. Okay, this has been a fantastic practical overview. Now, I'd love to maybe geek out a little on the science behind it all. We mentioned GLP-1 is a natural hormone. What is it, like chemically?
Okay, yeah, let's dig in. So GLP-1, or glucagon-like peptide 1, it's what scientists call a peptide hormone.
Meaning it's made of amino acids.
Exactly. It's a chain of amino acids, specifically 30 or 31 amino acids long, depending on the exact final form. And interestingly, it's derived from a larger precursor protein called proglucagon.
Proglucagon, related to the glucagon hormone we mentioned earlier.
The very same. They actually originate from the same gene. It just gets processed differently in different tissues to produce either glucagon, mostly in the pancreas, or GLP-1, mostly in the gut. Kind of shows how efficiently the body uses its resources.
Wow. Okay, so where in the body is GLP-1 actually made and released?
It's primarily produced and secreted by specialized cells lining the gut, specifically the small intestine. These are called enteroendocrine L cells.
Entero, endocrine.
Yeah, meaning they're in the intestines,
Right.
entero, and they secrete hormones, endocrine. It's also made by some neurons in the brainstem. And it's released mainly in response to eating food.
And you said there are a couple of active forms.
Yes, after it's made from proglucagon, it gets snipped into the active forms. The two main ones are called GLP-1 736, amide, and GLP-1 737. Those are the molecules that actually go and bind to the receptors and do the work.
Got it. You also used the term incretin earlier. What does that signify?
Right. And incretin is a specific type of gut hormone that increases insulin secretion after you eat. It's called the incretin effect.
So it makes the insulin response stronger.
Yes, but crucially, it does this in a glucose-dependent manner, meaning it boosts insulin release mainly when your blood sugar levels are elevated, like after a meal. It doesn't just stimulate insulin all the time.
Ah, that's why the hypoglycemia risk is lower.
That's a big part of it, yes. GLP-1 is a major incretin hormone, along with another one called GIP, glucose-dependent insulin-tropic polypeptide. What's really interesting, though, is that in people with type 2 diabetes, the body's response to GIP seems to be blunted, but the response to GLP-1 is largely preserved.
So targeting GLP-1 makes more sense for treatment in type 2 diabetes.
Exactly. That was a key observation that spurred the development of these drugs.
Which brings us back to the short half-life problem. If we make this naturally, why did we need drugs? Remind us again.
Right. The big hurdle was that natural GLP-1 is incredibly short-lived. Its half-life is only about 2 minutes.
2 minutes. That's it.
That's it. It gets broken down very rapidly, mainly by an enzyme called DPP-4, and also cleared by the kidneys. So only a tiny amount of the GLP-1 secreted from your gut actually makes it into your main bloodstream intact.
Not very efficient for a therapeutic effect.
Not at all. That's why drug development focused on two main strategies: creating GLP-1 receptor agonists molecules that mimic GLP-1 but resist breakdown, and developing DPP-4 inhibitors, which block the enzyme that breaks down natural GLP-1, letting it stick around longer.
Ah, two different approaches to boost the same system.
Precisely. And as we've discussed, the GLP-1-based treatments, particularly the agonists, have that added benefit often linked to weight loss and generally that lower risk of hypoglycemia compared to some older diabetes therapies like sulfonylureas.
Okay, the history here is fascinating too. How did scientists even figure out this GLP-1 thing existed in the first place?
Yeah, the backstory is pretty cool. It actually goes way back to the early 1900s. Researchers noticed that extracts from the intestine could lower blood glucose in animals. They called this hypothetical substance incretin.
Incretin, like the effect name.
Exactly. But then insulin was discovered, which was obviously huge, and interest in these gut factors kind of waned for a while.
Understandable.
But it picked up again in the 1960s. Scientists did experiments showing that if you gave people glucose orally, by mouth, it caused a much bigger insulin response than if you gave the same amount of glucose intravenously, straight into the vein.
Oh, why would that be?
That difference strongly suggested that something released from the gut after eating was amplifying the insulin response. That really reignited the search for these incretin hormones.
So when did they actually pinpoint GLP-1?
The big breakthrough came in the mid-1980s, around 1986. Researchers, including Joel Habner and Svetlana Mozov, used molecular biology tools to sequence the proglucagon gene. They discovered that this gene didn't just code for glucagon, it also contained the sequences for other related peptides, including what we now know as GLP-1.
So it was hidden inside the glucagon gene sequence.
Essentially, yes. They found that in the gut, the proglucagon molecule was processed differently than in the pancreas, yielding GLP-1, specifically identifying GLP-1 737 instead of glucagon.
And I heard Svetlana Mozov played a particularly key role.
Absolutely. Her work was incredibly important. She was instrumental in actually identifying the specific active form of GLP-1 that stimulates insulin secretion.
How did she do that?
She synthesized different fragments of the predicted GLP-1 sequence and tested their biological activity. She demonstrated that a specific fragment, GLP-1 737, was potent at stimulating insulin release from pancreatic cells. Early experiments in labs, including collaborations between Mozov and Hebner, confirmed this in animal models.
So she really nailed down the functional part.
She really did. And then clinical studies in the early 1990s started showing that infusions of this synthetic GLP-1 could indeed lower blood glucose effectively in humans, including those with diabetes, confirming its therapeutic potential.
What an amazing discovery journey. But then came the challenge of making it last longer, right? That 2-minute half-life.
Exactly. That short half-life was the major roadblock for turning GLP-1 into a practical drug. You couldn't just inject natural GLP-1 constantly.
So how did they solve that? You mentioned liraglutide.
Right. Dr. Lotte Knudsen and her team at Novo Nordisk were pioneers here. For liraglutide, they cleverly attached a fatty acid chain to the GLP-1 molecule.
The fatty acid, why?
That fatty acid allows the drug molecule to temporarily bind to albumin, a common protein in our bloodstream. This binding protects it from being broken down so quickly and slows its clearance by the kidneys, extending its action significantly, making it suitable for once-daily injection.
Ingenious, like giving it a protective shield and an anchor.
Kinda, yeah. And then there was exenatide, the first one approved. That had a totally different origin story, right?
Oh yeah, the Gila monster. Tell us about that again.
It's a great one. Scientists discovered a peptide in the venom of the Gila monster, a lizard found in the southwestern U.S. and Mexico. This peptide, called exendin-4, happened to be structurally similar to human GLP-1.
Just by chance.
Apparently. And crucially, exendin-4 was naturally resistant to breakdown by that DPP-4 enzyme. It had a much longer half-life than human GLP-1.
So they basically borrowed a solution from lizard venom?
Pretty much. They developed a synthetic version, exenatide, based on exendin-4, and it became the first GLP-1 receptor agonist drug. Who knew, right? Lizard venom leading to a diabetes drug.
Incredible. And then came semaglutide, which seems to have made even bigger waves, especially for weight loss.
It's exactly. Semaglutide involved further clever modifications to the GLP-1 structure, building on the principles used for liraglutide, but achieving even greater stability and a longer duration of action, allowing for once-weekly dosing. And yes, clinical trials showed particularly impressive results for weight reduction, leading to its approval for obesity as well.
And now we even have dual agonists like tirzepatide.
Right, targeting both GLP-1 and GIP receptors. That's shown even more significant weight loss in some studies. The innovation just keeps coming. It's really revolutionized how we approach treatment for both type 2 diabetes and obesity over the last couple of decades.
Wow. We have certainly covered a lot of ground today on GLP-1 agonists. From the basics of what they are and how you take them.
To how they work mimicking our own hormones, the benefits beyond blood sugar and weight.
Right, the side effects, the risks, and that whole fascinating scientific journey from early observations to lizard venom and sophisticated drug design.
It's clear they represent a really major step forward in managing metabolic health.
Absolutely. The whole story of GLP-1, it's just a fantastic example of how scientific curiosity, collaboration, and persistence can lead to therapies that genuinely change people's lives.
Definitely. And the research isn't stopping. It really hints that we might find even more uses for these kinds of approaches in the future.
And just a reminder for everyone listening, if you have specific questions about whether GLP-1 agonists might be suitable for your own health situation, please always talk to your doctor or healthcare provider.
That personal medical advice is key.
Yeah. We hope this deep dive has given you some valuable insights, though.
It was great discussing it.
And this deep dive was brought to you in part by StoneFly.
Right. StoneFly leaders in data center solutions.
Offering that high-performing, elastic, always available IT infrastructure powered by their intelligent Stone Fusion OS. They cover cloud, storage, backup and DR, hyper-converged solutions. Really comprehensive.
Yeah, and check this out. StoneFly has a pretty amazing offer right now. A 100 TB immutable and air-gapped SSO NAS for just $8,195.
100 terabytes. Immutable, air-gapped. That sounds like serious data protection.
It really is. Robust security, making sure your critical data is safe and always accessible when you need it. You can find out more about this offer and all their solutions on the StoneFly website.
Definitely worth a look. So before we sign off, here's a thought to leave you with. Given the success story of harnessing a gut hormone like GLP-1, what other internal signals, maybe hormones or neurotransmitters within our own bodies, are just waiting to be understood and potentially tapped into for future medical breakthroughs?
Makes you wonder what else is out there.
It certainly does. Food for thought. Thanks so much for tuning in to vpod.ai.